here's kind of the idea tonight. The idea is you saw all those consult questions. I talked to a lot of people. And all the questions I get are, I mean, for the most part, honestly, are good questions. I mean, they're some of them are fairly straightforward, but I think the others are people calling saying, hey, is there anything new? Before I do what I think I'm supposed to do, is there anything else that I should be doing different right now? The thing I thought about was, when I was trying to come up with something to talk about was, I'll get that question and talk to that one person, and that one person goes, oh, that's great, thank you. But that's only one person. So, like, is there a way to take those good questions and disseminate them out so everybody gets to benefit from it? Because I do find myself sometimes answering the same question over and over, and I'm like, hey, I should do a talk and not just talk about common questions. Also, as we're going through this, if you guys go, oh, I have a question, we'll fire off, and we'll keep it fairly casual, and certainly I want you guys to get as much as you can out of it. But the goal for me is to hit some of the major things that we talk about, or that certainly you'll see every day. In this talk, you'll see lymphoma, mast cell tumor, bone tumors, melanoma, hemangiosarcoma. I mean, I threw a few things out there that I thought would be just reasonable things and questions that are commonly asked. So the first one is lymphoma, certainly one of the most common diseases that we run across in our world every day in veterinary medicine. So one of the major questions I get is, I have a dog that comes into my hospital. It has multicentric, multiple lymph nodes enlarged. How do I confirm my suspicion of lymphoma? For everybody in the room, and I mean everybody knows this, but it's good to know, is that whenever you see a dog that has enlarged lymph nodes, the number one diagnosis is going to be lymphoma. It's not fungal, it's not bacterial, it's not tick-borne, it's lymphoma. Unfortunately, it is certainly the most common cause for a dog to have big lymph nodes, and so that's what you should always be thinking about when you see it, especially if the dog is fairly asymptomatic, because a lot of dogs that come into us are not sick. The owner's felt a lymph node, or you're examining them and going, wow, this dog's got big lymph nodes everywhere. So we're always thinking, when we feel those lymph nodes, how do I confirm my suspicion that this guy has lymphoma? I mean, the major answer is keeping it simple. I mean, a fine needle aspirate of the lymph node is your go-to. It's what I start with. And we collect that sample and we look at it. In most cases, that will get you the diagnosis. The question that I get is, what if it doesn't? You aspirate that lymph node just like you think you're supposed to, and the cytology report says, hey, it's suspect, questionable, couldn't rule out emerging lymphoma, possibly reactive, it's non-diagnostic, maybe you just didn't get a good sample, the cells weren't conserved. There's a variety of reasons, but I get this question on a fairly frequent basis, is we did cytology and it looks like it's inconclusive. What do I do now to confirm my suspicion? The next part of this is really saying, okay, our cytology failed us. What else is out there for us to confirm this? And so there are really 3 or 4 tests that can be done to confirm a diagnosis of lymphoma. The first one, and we're going to go through each one of these, first one is what we call immunocytochemistry, and that's basically doing special stains on slides. So not a biopsy, actually just an aspirate. The one that most people are commonly going to talk about is just a biopsy. We take a lymph node, or we biopsy a lymph node, and then certainly you can also do IHC or immunohistochemistry stains on that. And then the bottom 2 are the ones I want you guys to get more familiar with, and that's the flow cytometry and PCR for antigen receptor rearrangements, or a fancy way to just use the word PAR. These bottom 2 are the ones we're really going to talk the most about. But these 4 tests are really designed to try to help you get a diagnosis of suspect lymphoma when cytology doesn't answer the question for you. It also allows you to differentiate B cell versus T cell in the same fashion. So the first one here is FNA with immunocytochemistry. So this is my least favorite. I do not do this very often. We used to do it quite a bit in the first year or so of my residency, but it fell out of favor. The reason it fell out of favor is a couple of reasons. So one is it's fairly labor intensive. So you just took aspirates and they were non-diagnostic, and this test is asking you to take a whole bunch more aspirates. So you need at least 5 slides. So you're sitting there making all these slides, hoping they're good slides. You have to send all these slides in boxes and say, don't stain them all, because we're asking for these immunocytochemistry stains to be done. And then they're going to stain it with a variety of stains, and what they're looking for is just to try to see if they stained uniform, and the slides are going to be compared to some controls. The point of this is fairly labor-intensive test. You have to take multiple slides. They have to be good slides. And the downside to it is it's also fairly costly because all of those stains that you're running, each one of those stains cost quite a bit of money to run. So, immunocytochemistry is something that you can certainly do, but the big thing about it is you got to have a lot of slides and take some time and make some good ones. The next part is what we would refer to as just the gold standard. And the gold standard is a biopsy. So if you do cytology and your cytology is non-diagnostic, then a biopsy is certainly something to consider. I never think this is a wrong test. The negative with this test is it's just more invasive. You're going in and either removing a complete lymph node or you're taking a needle core true cut biopsy of that lymph node. But this is certainly what a lot of tests are going to be compared to, and certainly what we use as kind of the benchmark for the most diagnostic thing we have to confirm a diagnosis of lymphoma. You can also do the special stains after that on the biopsy to confirm B or T cell. One of the negatives with that is that by the time you do the biopsy and certainly you've collected the sample and you get that report back and then you request special stains, there's going to be a lot of time that passes during that scenario. And then certainly also you've got some extra expense now by adding special stains onto these. And so very diagnostic, but again, you're back into that kind of labor intensive. There's a time frame and a financial aspect of it that starts to come into play for these guys. So I get this question, hey, we didn't get the diagnosis. We were going to do a biopsy. I'm curious, is there a way to get this with less invasive? The owner's not really keen on me cutting the lymph node out. That's a question that comes up. And so that's where these next two come into play. So this is my favorite test right here. So this test is called flow cytometry. The idea about flow cytometry is that on lymphocytes and on a lot of cells, you have some cell surface proteins that we can actually add stain or antibodies to that will stick to those proteins and basically stain those cells. So the concept is that we make a small little culture. It's really easy to do. Once you do it once and you're like, oh, I know how to do this. This is really straightforward. But basically all you're doing is you're taking an aspirate of a lymph node. You're going to squirt that aspirate into a little red top tube. You put 1 ml of saline in there, and then you actually take a drop of serum from their blood. So you have to spin a little tube of blood down, but you put 1 drop of serum in there. So what you've done is you've got saline, you've got a drop of serum, and that's a culture. Basically, that's food within that serum, and you can actually just squirt aspirates of the lymph node right into that, mix it up, and just kind of looks like a little, mucoid little solution there. You put that on ice and send it to the lab, and those are live cells. So those cells are alive. They're able to label those with antibodies for the proteins on the cell surface, and different types of lymphocytes will express different proteins. So as this says, T cells will be CD3, B cells are CD21, and what they're looking for is just a clonal population. If these cells were all reactive, if they were out fighting off an infection, there's going to be some T's and some B's and some NK's and a little bit of everything there. If they're lymphoma, they're all going to be the same guy. They're all going to be either T's, they're all going to be B's, they're going to be this clonal population. And you're not only going to get a diagnosis of saying something like, this is homogeneous population consistent with neoplasia, i.e. lymphoma, you're also going to get, and this is a T cell or this is a B cell. The nice thing also is that they're actually able to look at the cells when they do that, and they'll actually say these are big or these are intermediate. And most labs, especially the ones that we send them to, are going to give you kind of their take on, like, dogs that have this same staining pattern have a prognosis of blank. So you get this nice write-up that tells you, yes, you have lymphoma, what type of lymphoma, and boom, this is what's going to happen with that dog if you treat it. And that's a really unique thing that this test can do. So this test costs about the exact same as if I take an aspirin and send it right next door. So that's what's cool about this test is I can, if I have a dog with lymphoma come in, I can run this test for a couple $100 and get all that information. No biopsy was done, no lymph node was taken, no dog was anesthetized. I don't have to wait on special stains, and I get all that information. So really a good test to start to think about if you have one of these, and once you do it once, if you guys have questions, I can kind of walk you through it. The lab that I use is Colorado State University for this test, because that's kind of like every school, and certainly a lot of different universities have their niche. You get your GI panels go to Texas A&M, your calcium stuff goes to Michigan State, endocrine stuff goes to UT. The Colorado State's the guys that if you got any kind of special cancer test like flow cytometry, their diagnostic lab does a lot of this. So if you go to CSU's diagnostic lab, they have flow cytometry, and they have this nice little neat form. There's like 4 people that work in the lab, so if you call them and go, I have a question, I was thinking about sending this, they're like super nice and we'll walk you right through it, and then you just FedEx it out to them. And then they run these samples every other day. So if I send them on a Wednesday, usually they'll run it Thursday, and I'll get a report within a couple days. They usually email me the results, and then they'll mail me or fax me an actual write-up on it. So within a week, I mean, you've got your answer. So the flow cytometry, the only negative with this test is the cells have to be alive. I have had several of these that have happened over the years. If that sample gets lost in the mail, if it snows really hard in Colorado and this doesn't get arrived on time, or somebody drops it off outside the door of CSU on a Saturday and they don't find it until Monday afternoon, those cells can die, and so now you got a dead culture, and those cells are just sitting there. Not all's lost, because PAR can be run off dead cells. So if I send it out there and they go, hey, we got your sample for flow, but all the cells are dead, we can still do this test. Now PAR is basically, they run this PCR out, and it's based on the weight of the cells, so they're not staining for cell surface markers. Those cells have to be alive for those markers to stick. And if they don't, well, then they can run those cells out on a PCR, and they're going to say, okay, do all of these run out exactly the same? So they all the cells run out the same, or are you going to have like these different staining or these different PCR patterns? So again, without going into all the science behind it, I mean, basically what they're doing is they run these assays and they look to see if all the cells do the same PCR pattern or not. If they do, then they can come back and say, look, these are all the same clones of each other, and this is what we expect. There's also, they can compare these to known patterns for T cells and B cells, so they can actually give you a T cell B cell diagnosis off of this. But this test can be run off blood, off aspirates. They can be run, like literally you can send them stained slides, and they can wash those dead cells off of the slide and run PCR on it. If your cells die in your culture, you can run it off of it. So these cells don't have to be alive. So one of the things is, let's say that dog came in, you took some aspirates, you sent some slides to the lab, they were non-diagnostic, or they couldn't call it. They come back and say, hey, I think it's lymphoma, I'm not sure, and you've still got some extra slides. You could just send those slides. You don't have to bring it back in and get more if you want. So there's some benefit with PAR, but it's not as good as flow. It's more labor intensive, obviously, with doing these PCRs. There's a little bit more lab error. It's not as sensitive, not as specific. If you look at them side by side, the flow is always my favorite, and I'll kind of show you an example of that. But the idea about this is not to overwhelm you and make you think that these tests are like something that's done and only done by specialists, or it's just really hard to do. I know the science behind these, but all you really have to know is I aspirate a lymph node, squirt it in a tube, put it in a box, send it to them. I just can tell you that these tests are where we're going, and the flow cytometry stuff particularly is more and more people that I work with are doing this test, and it's not cost prohibitive, and you get a lot of information, and you're seeing a large push away from cutting that lymph node out, because we now can do these tests and get some answers in a pretty straightforward fashion. So this was a study that was done a few years ago, and back in 2013, and what they were trying to do was say, what's better? So if you read lymphoma with immunophenotypes, they're looking at B and T cells, comparing it to immunohistochemistry, which is off a biopsy, flow cytometry, and then PAR. And so that's what they're trying to do. They're trying to say, hey, I want to do B and T cell, which one's the better one? If you just kind of muddle through all of this, what you find out was the sensitivity of the flow cytometry was significantly higher than PAR. So for B cell, 91% versus 67% for PAR. So 91% of B cells were diagnosed by flow, and PAR only got 67%. So that kind of gives you the little bit of an idea of which one was better. They bring it down and they do compare it here. Flow cytometry to IHC, which is your biopsy. IHC was 94%. So your biopsy still was better, just barely. That's why we still consider the biopsy to be the gold standard, but it's pretty dang close. And so that gives you an idea. Flow cytometry is something to just generally know about. Again, in general, it's preferred. It must have a fresh sample. They must be overnighted, but it gives you a lot of information, like phenotype, like what kind of cells you have, and it gives you that prognostic stuff they compare to. PAR is good if you only have a few cells. It's a weird sample. PAR they'll do off some stuff too. I've seen people do it off like spinal fluid and things out of like the chest and the abdomen, and those cells may be dead, but you can still do it off of that. So that's one of the pushes. Sometimes they'll recommend PAR. I've had some like weird effusions in the chest and the abdomen, and we say, I couldn't really get an answer. Can we do PAR off that fluid? And then they can. So so it doesn't have to be a live sample. It doesn't have to be a fresh sample. They can even do it off slides. So that's kind of the scenario with the PARs. It's more of it's a test that can be run off just about anything and give you some information, but I still think the flow is the one that I want you to get comfortable with when you have these tough cases. Still get this question all the time. What's the treatment for lymphoma? Like what is the go-to treatment right now for lymphoma in dogs? And it is, I won't spend a lot of time because it is exactly the same thing it's been for years, and it is that multi-drug chemotherapy protocol is considered a gold standard, and I tell all my clients this. Basically with lymphoma, we know there's a lot of drugs that you can treat it with. We know there's a lot of drugs that dogs respond to. Everything from prednisone to vincristine to doxorubicin, they all respond to this to some degree. What we know is just there's just not anything that's perfect. The best success we've ever had with lymphoma is not putting all our eggs in one basket. I mean, we really try to get some diverse protocol there that's going to target this from different directions and improve our chance of not just getting the lymphoma under control quick, but hitting these cells, getting a variety of cells eliminated, and we've always seen those dogs do the best and maintain remission the longest if they're treated with a multi-drug approach. That multi-drug approach that everybody hears about is a CHOP or Wisconsin-Madison protocol. It's what I use. It's what most people use. Your Cytoxan, doxorubicin, vincristine, and Pred. L-spar is sometimes included in that first treatment. Right now, L-spar is a little bit hard to get, and so it's compounded. And I still use it. I use it a lot, but I have a lot of dogs I just start with vincristine on. But it's considered to be the most effective treatment that we have for lymphoma in a general basis, especially for your B-cell lymphoma dogs. I think that the positive with it is very diverse. The positives with it is the numbers consistently in every paper always look the best when you compare protocols to Wisconsin-Madison. It usually is the one that's going to come out on the top. The negative with it is it's anywhere from a 19 to a 25-week protocol. And so most dogs are on chemotherapy for up to 6 months. Certainly the number of treatments they get is usually around 16 treatments. So usually it's 4 cycles of 4. So we know that's a lot of drug. We know it's a long treatment course, and we know there's a lot of cost that goes into treating those dogs. The scenario though is if we just look at the gold standard, it is considered the best treatment we have right now for lymphoma, and we'll talk more about some prognosis and stuff here in a minute. This protocol was out for a while, and this is where we pulled doxorubicin out of it. Doxorubicin, the reason we would use this protocol is 2 reasons. So a lot of people aren't super familiar with this protocol, and I will tell you I don't use it a ton, but I will use it in a couple of cases. And so it has your Cytoxan or cyclophosphamide, your vincristine, your prednisone, but instead of doxorubicin, it has cytosine, arabinoside, or cytosar. So cytosar is a drug that has incredibly high penetration into the central nervous system. So it's a very cheap drug. It's a very easy drug to give. Relatively easy drug to give. You give it IV, but you have to give it in fluids. So you load a bag of fluids and just let them hang out for 6 to 8 hours while that drug runs in. So I guess you could call that easy to give. It's a long treatment. But cytosar has a lot of penetration in the central nervous system. So if a dog comes in and he's had seizures, he's stumbling, he's walking weird, we think he's got CNS signs, then we will use some variation of this protocol. The other is that cytosar is fairly cheap compared to doxorubicin, so it can be used as a cost-saving protocol. But most people don't do that because I don't think it saves that much when you really start to look at fluids and keeping them in the hospital for a day while they're getting treatment. I think the main thing is that CNS, and if you have a CNS dog, this protocol seems to be the one we gravitate to. But the reason I throw it on here is because if you compare COAP and Wisconsin-Madison, they're really close. I mean, this is a study of 71 dogs in the co-op and 30 dogs in the Wisconsin-Madison, and it was 309 days versus 275 days. And so both of them were like pretty much right at that 10 to 12 months. I mean, that's kind of what we were seeing with that protocol. And this is older studies back in 07, but it just showed that those protocols, those two are pretty close in how they're used. I quickly threw this one on. This is a multi-drug protocol too, but you'll see some buzz on this protocol MOPP, mustargin, vincristine, and a drug called procarbazine in Pred. This protocol I use predominantly myself as a second-line rescue treatment course. It's been around forever, but the reason it kind of got a new buzz and found its way back out into the market and people using it a lot more now is because a paper was written a couple years ago showing that it may have an improved response and improved survival time for dogs with T-cell lymphoma. Mustargin seems to be a really effective drug for T-cells, and so this study came out in 09, and it basically said that overall response rate was high. 98% of dogs responded to it, and this was a virgin lymphoma dogs, first treatment course, not a rescue. Came in, they diagnosed them with T-cell and said, let's treat them with MOPP. The study overall, if we weed all the way down through it, it says the median overall survival time for the entire study population was 270 days, and 25% of the population was way out there. So that's pretty unheard of for T-cell dogs. I mean, that was a big deal, and a lot of people jumped on this because it was a chunk of dogs. It was 55 dogs that were treated with this. The big negative with this was 20% of the dogs required hospitalization for treatment-related complications, and that's too many. I mean, it's too many dogs if 1 in 5 are hospitalized. So what we were seeing in this is the protocol is good. It knocks out that T-cell pretty hard compared to what we were seeing with the other two protocols, but it's a pretty aggressive one. And it really, it was one of those that I've used MOPP a lot. And I mean, you'll have some dogs that tolerate it well, and you'll see some dogs that don't. It's just a lot of drug. I mean, the way it's given is you actually give mustargin, vincristine. You give both of those on the same day, and you do that week 1 and you do that week 2. You also give procarbazine, which is a chemo pill. You give that every day starting on week 1. So they get 2 doses of chemo day 1. They start oral chemo the same day, and they run on that for at least 2 weeks, and then they run on Pred for 3 weeks. So they get a week break, and then you hit them again with 4 more doses of chemo and pills. So these dogs are just getting nailed like every day and then getting 2 doses of chemo every week. Now, they go in remission, and they can stay there a long time once you stop MOPP, but it's a pretty intensive one, so I don't use it very often. I don't use it very often because of the side effects. I mean, and I've talked to owners about it quite a bit. I do use it for rescues, and I have kind of put some of those drugs into protocols if I know you have T-cell to see if we can improve our response. But it is one that's out there. Mustargin is also, this is also something if you guys are, any of you are doing some of these chemos, this is a protocol you don't want to mess with, because mustargin is mustard gas. I mean, it is a derivative of the thing that you think it's a derivative of. So it comes in a powder. It has to be liquid. It comes in a powder. If you break that bottle, if you aerosolize it, you breathe it in, you can get really sick from it as a human. So it is a pretty dangerous drug. When we use it, I mean, we gown up, and it's one of the ones we probably give the most respect to about just mixing and getting it into the dog and minimizing exposure, because it's kind of a nasty drug with a nasty history. But the study, again, I won't go into too much more on it. I mean, I think it did show that there are some drugs out there that work better for T cells versus B cells, and that one is one. So yeah, so we know our multi-drug protocols is where we go. Is there anything new for lymphoma patients? And certainly the next question is, can something be done post-chemotherapy to help maintain remission? So there's a lot of people out there that will call me and say, I actually treated this dog. Owners want me to call and say, is there anything else I should be doing now? Or is there anything else out there new? And so if you'd asked me a year or so ago, I said no, but now there is. There's something called the canine lymphoma vaccine. So what most of you are probably familiar with is the canine melanoma vaccine. Well, this is actually, Mariel has now licensed and have come out with a canine lymphoma vaccine. Do we offer it? Yeah, we offer it, and I do recommend it. This is brand new, so this hit the shelves in the spring of this year, and so we started using it this last year. I will say we haven't treated a bunch of dogs. I mean, we've probably treated somewhere around Gosh, I probably have like 5 or 6 dogs that we've treated. I mean, and we treat a lot of lymphoma dogs, so it's not the majority of the population by any means. And there's a couple of reasons for it. One is it's new, it's just brand new, and so the data, and I'm going to go over that in a minute, is a little bit small. And then the second is that it's costly. I mean, it's by the time you get all the way through your chemo protocol, and then this is something that's given after the chemotherapy protocol. And then the second is you got to hold your remission. I mean, you got to be a dog that gets through your chemo protocol, go all the way through it, hold your remission, and then start this up after you finish your chemo. So you really need to be about 7-8 months from diagnosis in remission when we started. Right now, this is a conditionally licensed product by Marielle, meaning that it's under evaluation by the FDA for approval. So they have picked out veterinary oncologists to use it for a year or so, and if everything goes smooth, then the FDA will give you the thumbs up. They just don't want any big issues with it, and they want to make sure it's being used in dogs. The drug is basically is used as an immunization for dogs with lymphoma, absolutely, not predominantly, absolutely only B-cell dogs. So it's only made for B-cell lymphoma that have achieved remission, completed their chemotherapy protocol. You give them this immunization. It's 4 transdermal injections, just like the melanoma vaccine. They're given once every 2 weeks. And basically, the goal is to stimulate the immune system to hold your remission longer. So there's been no significant reports or side effects listed with it. I mean, basically, it's super safe. So the question is, does it work? Well, here's how it works. It challenges the host, the dog's immune system, by exposing it to what it perceives as a foreign marker. The marker is CD20, which is a common antigen that's expressed on all the surfaces of B cells. So that's what that flow cytometry would stain for, is this CD20 cell surface marker. So the way it's made is it's actually a mouse CD20 B cell that's made into a portion of dog DNA, and then it's injected into the dog. So it's a xenogenic immunotherapy. The mouse DNA, or the mouse CD20, is injected in the dog, taken up by the host, but basically it's different enough from the canine CD20 that the immune system goes, that shouldn't be here. And so it mounts this response against that CD20, and those antibodies are produced that start to attack CD20. It'll hit basically the canine B-cell CD20 because the immune system cannot differ between the mouse version or the dog version. So it starts leading to destructions of all these neoplastic B cells, and basically the goal is to keep you in remission. Now, what we know is it doesn't work as a treatment. So you cannot inject this into a dog with lymphoma and his lymphoma go away. I mean, that's definitely something they tried and it doesn't work. What they found was, though, if you take you through chemotherapy, you're in remission. We know when dogs go into remission, they're not cured. We know they still have lymphoma. It's just at a very, very low level. Now your immune system has a fighting chance. It just is what your immune system can do is limited. So it can attack low levels of disease. It cannot attack big bulky disease. And that's just a concept that a lot of people struggle with, to say, well, I just want to treat everything with my immune system. If I can just stimulate the immune system, I can fight off anything. No, I mean, your immune system has a limit. It can only do so much. And so what we know is that in the pilot study, when dogs were in remission, it stepped in and it definitely made a big impact. If they weren't in remission, those dogs didn't do well with the vaccine. It didn't do much. And so what we saw with the lymphoma vaccine when it was added is that normally historical data is if you just use CHOP, if you just use the Wisconsin Madison, we'd only get about 25% of dogs to live for over 2 years. That was a limit, is only about 25% of dogs would make 2 years and go beyond that. And we would hover somewhere in this 10 to 12 month number. When they added that vaccine in after, we saw 50% of dogs go greater than 730 days. So this was a huge deal. I mean, when it first came out, I remember they presented this at our oncology meeting, and like everybody in the room was like, no way. Like this is no way. There's no way. We've been treating lymphoma for years and years and years. There's no way that boosted it that much. I'm going to the oncology meeting next week. It's in October every year, and they're going to present a whole bunch of this because a lot of people have been using it this year. So the question will be, is this real? Because, and I mean, I'll tell you right now, I don't know if it's real. Because the problem is there were 10 dogs in the study. So the question is that's a super low number. Like that, the Mariel threw out 10 dogs, said here's what they did. They doubled your survival time. Everybody buy our product. So is that real? I don't know. I mean, if it is, it's a game changer. Now we got dogs that can be vaccinated and they can live for, they can live for twice as long as they would with chemo alone. Now if they come back and say, hey, we got 13 months instead of 12 months or 15 months instead of 12 months, I mean, it's going to be a little bit of a kind of a debatable thing whether we should do it or not, because it is an expensive drug. Right now, this vaccine, Mariel has it. It's about $2,500 to add on to the end of it if they go through their chemotherapy protocol. So these guys come through here. They've spent $3,500 on treatment or $4,000 going through diagnostics and treatment, and now all of a sudden at 6 months we're saying, hey, $2,500 more, and we can, So that's the issue. Is if it was $250, I'd do every dog that came through the store would get one. But that's the hurdle with it right now, because that conditional licensure, they've got it set at a price, and that's what everybody pays, whether you went to UT or here or wherever. So we buy it. When somebody wants it, we buy it by the box. And there's 4 shots in it, and that goes to that dog. Now, problem is I've thrown some away. Unfortunately, that was a tough day, but because there's dogs that you inject and they come out of remission on the second shot. And so you're like, well, put that back in the fridge. We don't charge an owner, just so y'all know, for the whole box. I mean, we charge them per dose. So if they came out, I eat the other 3 bottles. But it's because I want to treat them. But I think at the end of the day, it's I've had a couple that came out as we were doing it, and that's a huge bummer. The worst one I had was recently. I shouldn't even tell you this, but the worst one I had is I just finished it. The dog's lymphoma. It's a great dog. It's a golden retriever. She's been doing wonderful. And I get an email from a veterinarian, and he says, hey, why don't you look at this picture on this dog that has lymphoma, or this X-ray on this dog, and tell me I'm crazy. And the dog has a bone tumor in its knee, and there's no question it's bone tumor. And I'm like, well, that's not lymphoma. And so this stuff happens. I mean, but it was so. I mean, these people did everything and did the vaccine, and like the dog's doing great, and then it develops a bone tumor, and it's I think it's like tibia or femur, and I was just like, wow, okay. The point of all that is, I think this is brand new, and I think there are some unknowns about it. I do think that it's really intriguing to see that study that 10 dogs even did that. I mean, because if it's remotely real, then that's a big deal for lymphoma treatment. And what we would do would be get them in remission and get the vaccine in them. I mean, that would be the new treatment course. And so the vaccine is super safe if you got the right clients and they're saying, you know what, we want to do everything we can. I mean, I would definitely consider it in my dog, because I will tell you, if I rescue that dog with more chemotherapy, then I can definitely spend $2,500 over the next year trying to keep them in remission. If I knew I could give them the vaccine and hold them with just that for a year, and they never have to give their dog any chemo, it's definitely money well spent. I mean, there's no question about it, because and they can just go home and enjoy another year. I mean, so it's I think it's an interesting thing to consider. I hope to have more information, and we'll see what the numbers look like in the upcoming year. But I just want you guys to know what's out there, because it certainly may be something you get questions about. Owners are considering referral. Get this question every day. Owners consider referral. Before I send them over, what's the prognosis from this patient? I have no idea where some of the numbers come from. People, quote me, but I'll have, is it still 2 months with treatment? No, it's better than that. We're doing a lot better than that. But I mean, some of these numbers have just changed so much, and there's this concept of what's called stage migration. And what stage migration is that we as veterinarians now do this. We have actually made numbers look better on accident, because we're diagnosing dogs way before we used to. So stage migration, and lymphoma is one of those that it's hard to migrate it too much because it progresses so fast. But you'll see a lot of dogs with bone tumors and liver tumors and things that, like, studies will come out now, and they'll say, hey, these dogs, we're doing this, but this study shows these dogs are living 2 or 3 months longer than they were in the last study. Well, it's because the last study was done in 91, and we weren't as good as picking up on stuff and diagnosing it. And so the stage migration is we haven't done any better with our medicine. We just done better with our diagnosing it. So we just actually moved the start point back 3 months, didn't move the end point forward 3 months. If we look at lymphoma, the prognosis is that, and I just kind of include all this because this is like if you just went through all the papers and put it in here. But your response rate should be over 90%, and we should see dogs live for at least 12 months. I mean, that's the concept when we treat it with a multi-drug chemotherapy, conventional chemotherapy, no vaccine. I should be able to have a dog that comes in here and very commonly get those guys in remission in the first few weeks and hold their remission for a year. I mean, or certainly get them another quality year. I mean, that's what we're talking to people about when they come in the store. That's what you guys need to know I'm going to talk to them about. And this is a real number. We will see about 20 to 25% of the cases we see here go 2 years. I mean, that's a real number. Now, that means 75% of the dogs did, but that's not 2%. I mean, that's a 25%. 1 in 4 dogs will live 2 years that are diagnosed with lymphoma and treated with chemo. That's what we're really hoping for. This is what you make decisions on. And so that's what I talk to people about. The rescue protocols that we do, they're all over the place. You'll see things like 60% response rate or 50% response rate, and you'll see things like 1.5 to 2.5 months. A lot of that depends on when you come out of remission, how long you held your first one, but if dogs are having a lot of trouble, I mean, usually when we go through rescue protocols, I'm going to get them another 2 or 3 months when I do that. That's kind of what I expect. So if you treated a dog, he came out of remission, he came over, I should be able to get him back in and at least get him 2 or 3 more months down the road if we just use another protocol. So that sometimes is enough. Somebody like right now came in and I said, well, you're out of remission, I can try this new protocol. It's very likely I'm going to get them into the first year. I mean, that's kind of the thought process when we talk about it. So second line treatments are a lot different. It just shows kind of the population you're battling at that point. We'll kind of blast into this next part. So this is bone tumors. So osteosarcoma, I get a lot of questions about it. I have a lame dog I took radiographs of, and I'm suspicious the dog may have a bone tumor. What should I do next? I love looking at radiographs for people, but I get a ton of radiographs, and I'm not a radiologist, and it's fine. I mean, I can happy to give you my opinion, but it's important for me to tell you, like, this is, you guys should definitely be doing some of this. I mean, films to the radiologist for an official rad review. It's, if you have digital, even if you don't, sometimes you can still take pictures and send them to them. It is just a great thing to do because these guys look at so many more films than I do. I'm definitely going to tell you, I look at a lot of bone tumors and I feel very comfortable going, hey, I think that's a bone tumor. But my report is not going to be like a radiologist report. I mean, they see the weird stuff. They go, well, actually, I've seen one of these once before. This is a blank. And I'm like, oh, I've never seen that. You know, remember, I just see cancer. So if you're saying, is this cancer? Then the answer is like, yeah, it kind of looks like it, but I don't have that list of all the other weird bone stuff that they see. If you have a film and you're really on the fence, I mean, I'm more than happy to look at it, but I will tell you a lot of times I'll end my conversation like, this is what I think, but this may be a good one for you to get a radiologist's opinion and see if she differs with what I'm saying, because reading films is what they do. It's also really easy, really cost effective, really fast. I mean, anymore you can throw these things in any of these online viewers, and I mean, within an hour, I mean, they've got your rad review that's sitting there that tells you like all their differentials. And I think, I'll be the first one to tell you, I think that some of the reports are better than others. I think that there are some people that read them that really puts a lot into it and give you a lot of information, and then some people that are like super short, and you just kind of have to, if you get one of those, almost pick up the phone and go, well, all right, tell me a little bit more about this, you know. So again, I'm always happy to look at it, but I do get a lot of films emailed to me, and I usually try to give my opinion on them. But again, I think if you're in that room and you're trying to get the owner's opinion, bringing it up to send it to a radiologist is a good thing to consider. The things that I'm looking for and the radiologists are looking for are some of these key radiographic findings. So it's going to be in one of those common spots, so distal radius, up in the shoulder and the proximal humerus, or around the knee here in our distal femur, proximal tibia. I mean, those are the, you know, the away from the elbow, close to the knee scenario. I mean, that's definitely those common locations. This is a big one. Bone tumor should never cross the joint, and that is something that a lot of people have debated, but I will tell you 99.9% of the time it shouldn't cross the joint. So if you have some kind of change and you've got all this reaction happening and it's on the, you know, it's here and it's down here, that's weird. That shouldn't be a bone tumor. Bone tumor is affecting that one bone. It's growing from the inside of that bone, pushing outward, and it really should be that bone. And you can have some arthritis and stuff in a joint you don't want to confuse yourself with, but if you start to see that there's a big palisading reaction on the femur and down on the tibia, that's where I'm going to be thinking, hey, is that some kind of synovial tumor or something other than a primary bone tumor, because it's affecting both bones. Cortical lysis, breaking of the cortex, new bone production, basically this palisading or sunburst appearance where it's just a combination of lysis and production at the same time. Codman's triangle is supposed to be a kind of a pathognomonic thing that if you see it, it's definitely a bone tumor, and that just means that your periosteum is lifted up, and then the cortex is sitting here, and you kind of see this piece of bone, or this nice line that goes here, and then the bone's going this way, and so it's showing that the tumor is actually pushing that periosteum out, but that tumor is in here, but it's not calcified yet, so it looks like that it's lifted off of the actual cortex of the bone. So, breaking of the cortex, eating away, tons of chunks here coming out of it. You can get these that are just super loose, and this is like a really bad radiograph, by the way. Sorry about that. But it's got like some palisating stuff here on the back, but it's just kind of eating away. Both of those are bone tumors. That was kind of highlighting how different they are. But that's a Codman's triangle right there. You see how that line is, and then the cortex is over here. That's what they're looking for. This is picked up off, and then that's over here. That's your periosteum, that's your cortex, and that's tumor all between it that's pushing it off of it. So that's a not as sharp a one. Sometimes they're way more impressive than that, but that's an example of what they look like. Do they have, if they have consistent clinical signs? A lot of times bone tumors are just presumptive diagnoses. There's no question. You look at it and it looks like it, and the dog fits, and it's in the right location. People ask me, is it okay for me to refer this, or do we need a sample that says that it's a bone tumor? No. In fact, 99% of the ones that I see, again, are going to be coming in with a presumptive diagnosis of an osteosarcoma, either on swollen mass on it, or they've taken radiographs and say, yeah, this fits with a bone tumor. So are there any other causes for these changes in the bone? Sure. The first one, I put this list when I talk to clients, and I say, well, the first one is more cancer. These always are ones we talk about. Is it fungal? Is it osteomyelitis? Could it be a cyst? But actually, these are not as common as other types of cancer, and a lot of people skip over that. They'll say, well, it's either osteosarcoma or it's fungal disease. Well, it's either osteosarcoma or chondrosarcoma or synovial cell tumor or hemangiosarcoma or fungal disease. And so these actually are other types of cancers that are found in the bone that actually make up a lot more of those. A lot of people don't realize. And the good news is, if you have a chondro or a fibro, you can do better with that. Some of these will look different, but again, big lytic changes in bones, we'll consider primary bone tumors being about 85% of what we see. So that's going to be your osteosarcoma. Then you're going to have this small percentage that are going to be other types of cancers, and then you're going to run into the systemic mycosis and the osteomyelitis. These exist. I'll see one every couple years that turns out to be something like fungal disease. But I will say the ones that I've seen and the ones that I do see, and they're rare. They're really, really rare, because I will tell you, I get to the point where I have to catch myself and actually even consider them, because sometimes I just see the bone tumors and just go, boom, it's bone tumor. But those dogs really look different. They'll come in and they're sick. They may be running a fever. They don't feel good. The owners are saying, yeah. It's not that history of, we were playing ball and he came up lame. It's really like you start to feel there's something different about this one. This dog is just not happy. He doesn't feel good. The bone is hot. Something unusual. So again, it makes the list. We definitely go through that and we talk about diagnosing it versus treating it presumptively. Without question, presumptive treatment is the most common, treatment. We usually oftentimes get that diagnosis after we remove the leg, or we're treating it presumptively. But certainly we do sample some if it looks like there's some question of what's causing it. This comes into play a lot. I've got a bone tumor. Do I send this through surgery or the oncology unit? Always with the suspect bone tumors, send them through the oncology service. And the reason for that is because we have a pretty long discussion about limb sparing and amputation options. A lot more dogs that are treated anymore with radiation and medical treatments. We do a pretty good job. Amputation is always my recommendation if the dog can handle it. If he's orthopedically and neurologically sound, I will recommend an amputation for the majority of the dogs, because it is certainly the gold standard. My own personal dog was diagnosed with a bone tumor, and I treated her with an amputation and carboplatin. And it was, I will not lie, the day she was diagnosed, I was like, ugh, do I want to do an amputation? And I was like, I can't be a hypocrite. I tell everybody to cut their dog's leg off. I got to take my dog's leg off. But she did great. She ran around on 3 legs, and she had TPLOs on both back knees, and so she ran around on 3 legs for 16 months, and it was her front leg too that we had to amputate. It was in her shoulder. But her presentation was exactly the same. Running across the yard, came up lame. I was like, give you some Remedil. You just pulled something, and then like 2 or 3 days went by, and I'm like, you're really lame. I'm going to get an x-ray. And so we took a radiograph, and there was definitely a pretty gnarly tumor in her shoulder, and we took her leg off the next day. So pain control is the main reason I recommend amputation, because yes, we're looking at making them live longer, but there is no question. I mean, my dog, she ran around the house and laid here and did this and did that, but was comfortable. She was on very little pain medication for the time she had left, and she had 3 legs, but she was comfortable with 3 legs. And so amputation is considered truly for quality and for pain control, where your chemotherapy is really there for quantity and to help maintain that by slowing any further metastasis down. The dogs that have orthopedic issues, the owners just elect not to do an amputation, or there's some factor there that makes them not a good candidate. We do work pretty close with some of the radiation oncologists in south of here in Atlanta, and they do a lot of radiation for us for some of these guys. I have some that go to UT for it, and then we use some of the bisphosphonates that are out there now, pamidronate, zalidronate, to really kind of stabilize the bone, and we still get a lot of time. I mean, most of those dogs will get, if they do a short course of radiation, so like 2 to 4 doses of radiation to the bone and chemotherapy to kind of keep it from progressing, most of those dogs will get somewhere around 8 to 10 months, and usually 8 to 10 months is where that pain starts to become an issue. So the majority of them, by far, we euthanize them because of discomfort. Unfortunately, the metastasis, we usually keep it under control during that period of time. There's even some thoughts of maintaining the limb may actually reduce how fast metastasis grow, and that's a long conversation about just the inflammation of the tumor may actually act like these vaccines we're talking about and suppress their growth. But the pain we can't get away from. And usually after that radiation's wore off, the tumor's progressing, they've fallen on it enough times, they finally decided it hurts, and that's when we usually make a decision. With our amputation, we expect you to be well over a year. And we see 50% very easy statistics to remember if you're thinking about bone tumors. If you amputate and give 4 to 5 doses of carbo, 50% will make 1 year, 25% will make 2 years, 10% will make 3 years. And the 3 years does exist. They're rare, but they do exist. There'll be those dogs out there with it that just, they get a nodule in their lung, but it just slowly progresses and then finally becomes an issue 2 or 3 years into it. So it is a disease that I think dogs can do well with. Like I said, my dog went 16 months before her metastasis were causing a problem, but but again, I thought she was very, very happy during that time. Osteosarcoma in cats is pretty awesome because it has a really low metastatic potential. And so a lot of people, you don't see it very often. It's pretty rare. It's pretty rare to have a lot of cats with bone tumors. Maybe I'll get 1 a year or something like that. That's a true osteosarcoma in a cat in the bone. But most of them we will amputate. And the reason we amputate those guys certainly are because there's a lot of studies with amputation alone where that was a definitive treatment and the tumor never redeveloped. And so the statistics are really strong for cats with bone tumors with and without chemotherapy. So a lot of times people treat it as more of a locally aggressive tumor. Think about a bone tumor in a cat being more kind of like your soft tissue sarcomas. If you can get it and get a good local control, the metastatic potential is much, much lower. So in dogs, we talk about a metastatic potential of being around 90% in the limbs. In cats, we talk about a metastatic potential being like 40%, something like that. So I do chemotherapy on them occasionally. We'll do carboplatin and do 4 or 5 doses, but I will tell most people if you look at the studies, there are a lot that were treated with just surgery alone that went on and lived for a very long time and never had recurrence. And so in dogs, we would expect if we amputate your leg, it's going to redevelop somewhere. If we just did amputation and no chemotherapy, I usually tell people 6 months, 7 months, you're going to have metastasis somewhere if we just amputate. In cats, though, you could see that cat with amputation alone go on and live for a very, very long time. One of the most common tumors everybody's going to see, most common skin tumor that we see is mast cell tumors, and I get a lot of calls about it. And we'll start with this part right here. So I removed a mast cell tumor. I'm not sure what to do next. I need help with interpretation of this histopath report. there's grade, there's margins, high grade, low grade, 1, 2, 3, mitotic index. When did this get so complicated? And this is real. I mean, right now we're in a unique period with mast cell tumors because there was and where this all stems from. If you start to read your mast cell tumors reports, you get this kind of canned variation where it's like an extra page stuck on the back of your histopath report of like all this random stuff about mast cell tumors. And if you start looking for it, you'll be like, wow, why did when I send them a biopsy for some random thing, it's like this long, and then I send them a mast cell tumor, it's like 2.5 pages. And it is because a couple years ago they started a pathology, oncology, surgery, I forget what they even called it. It's basically like a task force. I mean, it was a group of people that met a couple times a year, and they were really trying to come up with a new grading scheme that pathologists could be consistent with, that really predicted more about how mast cell tumors behave, to really simplify the directions we should take them, because surgeons, oncologists were really feeling like what we previously thought we knew about them wasn't necessarily what we were seeing in clinics, and we'll talk a lot about that. On the other side of it was we were also frustrated with pathologists because there was 3 grades, 1, 2, 3, and about 87% of all the tumors we sent in came back as grade 2. And so we were kind of like, feel like y'all aren't trying hard enough here. You're just saying it's not that bad, it's not that good, so no, next one. So we really are now in a scenario where we're trying to and this is real. We're really trying to actually phase out the grade 1, 2, 3, the Patnick system, and we're trying to kind of eventually transition to this high grade, low grade scenario. So what you're going to see on your reports when you look at them nowadays is you're going to see grade 2, and then there's going to be parentheses or a comma, low grade, or grade 2, comma, high grade, or grade 3, high grade, grade 1, low grade. So they're actually going to be putting this, and they're not just saying, hey, I think this is a lower grade variation of it. They're saying like that's actually a totally different grading scheme that we're going to be transitioning to, and we'll talk about that. So, but I get this a lot. A lot of people call me, got this mast cell tumor, we took it off, we sent it in, where do I go from here? So this is where I was talking a little bit about. You've got this 2 thing that's going on right now where you have this 3-tier system and a 2-tier system, and realistically, trying to make sense of that can be complicated. If we look at the old scheme, it was very straightforward. Hey, grade 1 tumors are low grade. Their local growth is really slow. Their potential for metastasis is 5%. So we knew, take it off, probably not going to come back. Try to get a complete excision. We don't really worry about metastasis with those. So grade 1s were pretty calm, quiet tumors. Grade 2 tumors were intermediate, and they just had variable behavior. Everybody had one that did really well, and everybody had one that did really poorly. They seemed to be locally invasive. We thought the metastatic rate for grade 2 tumors, and still do, is somewhere around 15 to 20%. And it was really always about local invasion and being able to get a wide excision so it didn't recur. Grade 3 tumors are considered high grade. They're not nice tumors. They're growing quickly. They're pretty undifferentiated. Not only are they invasive, but they seem to grow over days and weeks, not over months and years. And their metastasis rates have been reported to be as high as 96% in papers. We talk about numbers like 80% of them can show up in a lymph node or somewhere else. And so these grade 3 mast cell tumors, when you see one, they definitely act in a more aggressive fashion. The good news is the grade 3 mast cell tumors really, in that 3-tier system, only made up about 10% of what we actually saw. So 90% of tumors are going to be in the 2 or the 1 category. Unfortunately, 80 to 82% of the tumors are in the grade 2 category. So what that meant was 10% went up, 10% went down, 80% went in the middle. And so that's what really drove this kind of task force to say, like, hey, this is not that helpful. We know basically when we send it in, it's going to come back as a grade 2. So tell us how we can do a better job at coming up with a grading scheme that works and is more predictive of behavior. So that's where this 2-tier system came into play. So the initial study that was done, there was 95 tumors from 95 dogs that was done. It was a blinded study. They had 28 pathologists from 16 different institutions. Basically, they said, anybody and everybody in all the vet schools that are willing to play, let's see what y'all can come up with. Here's 95 dogs, and let's go from there. So they asked them to do a simple thing. They said, hey, classify all these mast cell tumors as either high grade or low grade. Just put it in one of 2 categories. And so they did. And actually it was really, that initial paper and that initial study was actually really predictive of what these dogs were going to do. I mean, there were very few people who differed on which category they went in, and most of them were super accurate. And the first paper was kind of crazy because it showed, as you can see here, if you got put in the high grade category, your median survival time was somewhere around 2 months. It was like 2 to 4 months. And if you were in the low grade category, it was like 2 years. And so it was super predictive of behavior. Now, not a lot of dogs got put into this, but the ones that did really poorly, and everybody else did pretty dang well. This is what you will actually see on this study, is what you'll see if you read through that second page of your histopath report. You'll see something in there that says that mitotic index is a predictor of behavior. If it's greater than 7 on your report, you have a survival time of somewhere around 4 months or less. If your mitotic index is less than 7, we see up to 70 months survival time. So really interesting, but the mitotic index is something you got to keep in mind when you get those studies. I mean, that can be a huge predictor of behavior. I had a dog the other day that had a mitotic index of like 32 or something, and I'm trying to explain to him like why I'm recommending chemotherapy for them, because that thing was so hot. And they're like, well, let's go home and think about it. The dog comes back like this week, like literally like 8 days later, and it's already grown back. I mean, there's like, and that just shows you like that's all those cells are just replicating so fast. It's just boom, it's back. And so the ones that are come back a mitotic index of 0 or less than 1 or 1, I mean, those tumors aren't going to be that aggressive. I mean, those tumors are going to be pretty quiet. So this is something to get comfortable with. If you see it greater than 7, get nervous a little bit, and we need to start thinking about treating those more aggressively. Less than 7, they can do really well. So this was that first one that came out. The concern with this is there could be a downgrading of potentially aggressive tumors, because you could have some that get thrown into that low grade category that even though the mitotic index isn't that high, they still can act a little more aggressive. But I can tell you this system right here is already way better than that 3-tier system, because we saw a much more accurate predictor, and this study's been repeated a couple times now, but a much more accurate predictor in the true behavior of the tumor in question. So there are a lot of different factors that have been looked at for prognostic factors. So location, grade of the tumor, obviously the size of it, mitotic index is a big one. You can go all the way down through here, breed, and then they've got all these weird little things like c-KIT, P53 mutation, Ki67. This is that if they ever ask you to add like sometimes if you send it out, they'll say, we recommend you do this panel, this mast cell tumor panel. I don't really recommend people spend their money on that too much. I mean, we really hang our hat more on this guy up here, this mitotic index and the high and low. I don't think this adds a lot. I think it's something that the labs are kind of promoting, but after you run it, they don't really give you a lot more information after you get that, and it really hasn't changed a lot of what I do on a day-to-day basis. So I can't tell you to necessarily do those panels, but some of these are important. Some of those are ones that I will come up with, and really kind of what I'm going on here is, when do you need to kind of start to be talking about this being a more aggressive tumor, or potentially that this dog needs more than just a surgical removal of the mass, he needs chemotherapy. Obviously, high mitotic index was one of them. A high grade is going to be an indication for chemotherapy. The others are going to be things like subcutaneous tumors. So subcutaneous tumors, I mean, really all of these grading schemes are dermal grading schemes. I mean, they're made for dermal cutaneous mast cell tumors. They're not made for subcutaneous mast cell tumors that, you pick the skin up and the tumor's still stuck to his abdomen. Those are different tumors. It's not that they're necessarily way worse. It's just that we don't have a proven criteria for how their behavior is. I think some of them stay pretty benign. I think some of them are really hard to get underneath and remove, and the recurrence is higher for those subcutaneous ones, and I think some of them can behave more aggressively. I think locations like your prepuce scrotum, subungual, orals, I mean, those are definitely more aggressive. I mean, the ones that you'll find on a dog's scrotum or his prepuce or around the perineum, I mean, these have definitely been shown here, preputial versus other cutaneous sites, 4 months versus 33 months in a study. Here's one that was perineal and mucous membranes, and these guys see 9 months versus 33 months. So we know that some of those highly vascular, highly lymphatic areas, they're going to have a much higher potential for metastasis. And so those are ones that I worry a little bit more about, and worry about those tumors trying to move around. Visceral and bone marrow, I mean, if you run across a visceral mast cell tumor in a dog per se, or bone marrow mast cell tumor, which you just really don't see very often, but if you see them, I mean, you get these really short survival times of like 3 months, 2 or 3 months even with treatment. So we just know those are harder to treat. The caveat to that, and the reason I said that was caveat to that is a cat. If a cat can have mast cell tumors in their spleen, and it's weird, you can take their spleen out and then go and live for like ever and do really, really well. So again, I mean, apparently the take home tonight is cut a leg off a cat or take its spleen out and it lives for a long time, I guess. I don't know that. No, they really do. I mean, there is a paper on that, and it shows that like visceral mast cell tumors of the spleen in cats those cats can go on and still do very well with splenectomy, and we don't really know the mechanism behind it, other than a lot of times those cells must be staying fairly confined within that spleen, where dogs are usually they're going to highly circulate, and that's not going to be real beneficial. They're going to kind of move throughout the body. So location is a prognostic indicator. Breed is obviously a prognostic indicator, so we talk about these English breed guys right here. It's a positive prognostic indicator. So breed, boxers, pugs, Boston Terriers, they seem to have an improved prognosis with a trend to get lower grade tumors. They just get a lot of them. So your pugs and your Bostons and your boxers, we know they're poster childs to get these tumors, but majority of them are going to be just more of those lower grade categories, and so that's a good thing. But unfortunately, I will run across some of these guys that'll have 15 tumors on them when they come in, and so that presents obviously an issue of trying to figure out how do you treat that, because surgery is not always a good option if they've got lots and lots of them. So other prognostic factors, just real quick, I mean, these are the ones that I said that I don't know if they're cost effective. I don't know if there's a predictive value there that I can really lean on. I mean, this is done, and there is, it does correlate sometimes with aggressive behavior, but again, I don't know if it changes what I do, and typically you're not going to see this be detected and everything else be normal. So usually these panels, I tell people, I don't know if they add a lot of benefit in our world right now. But higher grade or metastatic mast cell tumors, I mean, chemotherapy is always recommended. Regional distant metastasis is the leading cause of death. And also with these high-grade tumors, we have seen that certainly that local excision is really important, because certainly, even though if I had to pick one, I'd pick chemotherapy because of the risk for metastasis. We do see a lot more of the high-grade tumors try to recur than the low-grade tumors, which we'll talk more about. In terms of chemotherapy, you've got the same options we've always had, so vinblastine and pred and lomustine and pred. I set this cytotoxic versus cytostatic because these are considered cytotoxic drugs. I mean, the idea is that these are chemo agents that are going to go identify the cancer cell and try to get rid of it. And that is the idea with using vinblastine or lomustine for mast cell tumors. Palladia, which everybody loves to talk about right now, is a static drug. It halts growth of cells. It does not, and is not supposed to go in and guns a-blazing and eliminate cancer cells. Now, these cancer cells can die off after a while, but the way Palladia works is it blocks these vascular endothelial growth factor, platelet-derived growth factor, your c-KIT. I mean, a lot of these stem cell factors will be blocked, and these growth factors will be blocked, really stopping that overall growth of the tumor. And then hopefully in that scenario, those cells will sit there being inactive and potentially start to dissipate over time. But it's not the same as your toxic drug. So I don't always use this in every case. I mean, some people really like Palladia. I usually start with vinblastine and pred. It's always been what I have the most success with. I'll either rescue with this drug, or there's some of these really low-grade tumors that maybe we'll use in place of some of the higher-grade chemos. And so there's just certain areas that I'll use it with. It's definitely not always my first line of defense against a really aggressive mast cell tumor. The big question is, I've removed a mast cell tumor, but the excision was incomplete/narrow. What should I do? Everybody's been there. Everybody's seen these. We all read this and was taught this when we went to school. Hey, you need to get 2 or 3 centimeters around it. You need to get one fascial plane, and pretty much nobody does. Or at least a lot of times we don't. Some of that's based on location. Some of that's based on the size of the dog. It's a lot easier to get 2 or 3 centimeters in a Great Dane than it is a Chihuahua. So the reality of it is how do you approach these cases, and how do you know what to do? Historically, we've told everybody if you have incompletely excised or low to intermediate grade mast cell tumors, that ideally you would go with something like radiation. You treat that site. It's very, very effective. I mean, that's a big number, 85-95% chance that if we radiate that area where that tumor was removed, you're going to eliminate it. But logistically, we know it's hard. The closest facilities right now we have is Knoxville, Atlanta, Auburn, Georgia. Duration can be somewhere around a month that those patients are going to be there going through treatment. So they get 16 to 22 treatments, and the cost is somewhere around $4,500 to $5,500 depending on where you go. So radiation is very effective, but there's some cons and logistic issues that arise from it. It also is very localized. Don't take the boxer that's going to get 15 and radiate the one on his foot, because he may have 10 by the time he leaves the facility, and that's really challenging. So the idea behind it is that yes, we know it's effective, but is it needed? And what's all the options? And this is where I sit down with clients and try to walk them through like what all those options look like, because I think there are alternative options to definitive radiation. So one option is a more aggressive surgery. I mean, there's plenty of times we go in and we remove it and go, I'm not really sure what this is, but you're here, you're under anesthesia for some other reason, I'm going to go ahead and take that mass off, and you get it off and go, oh, it was a mast cell tumor. I didn't realize that. So, I mean, it's not unreasonable to go back in and just widen your surgery. You're just going to pretend the scar's a tumor, measure out on each side, go around it, and then close it back up. I mean, I've seen them do that and not even take the old sutures out. I mean, we just leave them in place, cut it out, the biopsy still got the sutures in it. And so, you can do that. I mean, there are times where we get a deep muscle resection or really aggressive ones. I mean, I've seen people off these limbs, have to do a flap or a graft or, just a lot of, a mesh where they'll make the small incisions and pull it so there's not as much skin tension. But it's just allowing you to widen that excision. It's totally a reasonable thing to do, and a lot of times that can really eliminate the risk of some of these tumors recurring. This is a little controversial, but there are a lot of cases that we utilize here in this hospital to do this in. I kind of like doing it. I mean, I remember when I went through my residency, people were doing it, and it was kind of like a little bit taboo on whether we should do it. But we would inject some mast cell tumors, and we still do here every day, with triamcinolone. Just put a little Vetilog into the tumors, let them shrink down over a couple days. I typically will take a Sharpie before I do it and draw all the way around that tumor so I know where it was, inject it. Steroids will shrink that thing down and make it a lot smaller over the next few days, and then have them come back in a couple days and do surgery. So, if we do it, if I do one tomorrow, say come back first next week or next week sometime, and we'll do surgery. And that tumor will be a lot more small. It won't be as inflamed. You'll have your mark to know where the old one was, and you can kind of go around it, but it will make that tumor a lot easier to remove. The reason I like triamcinolone is because you don't have to go through the big tapering course of pred. So you don't have to be like, do this and then do this for a week and then do this for a week and do this for a week. You can inject it, it reduces, and then you can take it off. The reason it's controversial is because we never know if the fingers all pull back. So are you kind of making yourself feel better, but really there's still these fingers out here, and you're cutting and leaving them. But if you mark it, you kind of know where it's at. And I think that most of the time it does pull those back, and a lot of times we'll see that those things are coming off and just they're healing better, they're looking better, and they're not as red and inflamed after you did the surgery. Chemotherapy can be done as an adjunct following surgery if it's incompletely excised. I still do it. I really, to tell you to be honest, I don't know how effective it is, for especially for lower grade tumors. I mean, obviously, if it's a high grade tumor that was removed, I'm always recommending chemotherapy. If it's a lower grade tumor and we don't want to go back to surgery and do any more surgery, we know we left some tumor behind. I mean, I will treat some with vinblastine or some with Palladia, and I think that the results are good. They're variable, though. It's hard for me to quantify like how many of those patients that I think, hey, if I hadn't done that vinblastine, it would have definitely recurred in that lower grade tumor. But it is an option. It's something we do consider. But this is the one I really want to talk to you guys about. It is the old wait and see. You're not supposed to hear your oncologist say that one either, but he will. And the reason he's going to say it is because years ago, when I was, like I said, when I was going through my residency, I mean, they would tell you, like, hey, if you don't get it all, if you don't get to 2 or 3 centimeters, if you don't get the deep fascial plane, the tumor regrows. You know, you've got to go for radiation. You've got to get really aggressive with surgery. But the reality of it is that this is probably even being generous. I mean, there are some new studies that are coming out that show that the true low-grade mast cell tumors that we remove with narrow or even incomplete margins probably have more like a 50-60% recurrence rate. I mean, there are a lot of these tumors that we don't get them all, or we get a real narrow millimeter, 3 millimeter margin, something like that, that just don't recur. And you know, we set these guys up. I saw 2 patients today. Scars look great. They were both done, surgeries were both done at the referring veterinarians. They came to me. They were lower grade tumors, but they were incompletely excised. And both of those patients, after we went through, like, is radiation something we want to consider? We want to consider another surgery. Both of them are going in the scenarios where I'm going to see them at 1 month, 3 months, 6 months, 9 months. You know, basically just work our way out over the next year and see if anything's trying to recur. If something is, then we're going to step in and do procedure at that time. If not, we're going to kind of see what happens here. This is stemming from some of these papers like this. So this is 2015. Obviously, this is a weird spelled tumors. So this is, I'm sure this is European. Yeah. So but this is Veterinary Comparative Oncology. So it's one of our our oncology's main journal. But this is histologic grade and histologically tumor-free margins as predictors for local recurrence and in completely excised canine mast cell tumors. Now, this is completely excised tumors, but this is not wide completely excised tumors. These were like 1 millimeter, 2 millimeter, 3 millimeters. These were these really, really narrowly excised tumors. But the idea was, it's like, how big a margin do you need for your tumor, and what's the potential for it to recur? So as you go all the way through this, what they found was that high-grade tumors were more likely to recur than low-grade tumors. We know that was true. And they said that basically 35.9% of high grades recurred, where only 3.9% of the low grades recurred. And then they looked at 29% of low grade tumors had histologic free margins of less than 3 millimeters. So these were dogs that had, of the 3.9% that recurred, about 30% of those had 1 millimeter, 2 millimeter, or 3 millimeter margins. I mean, they had really, really small margins, and none of them recurred. So all of those dogs that had less than 3 millimeters, none of them recurred out of that study. And so narrow histologic margins are likely adequate to prevent low-grade tumors from coming back. I mean, that was the take-home on this paper. And it wasn't a small group. I mean, it was a pretty good group of dogs. There was a lot of good information in this thing. It was a great group that was there. They said, hey, high-grade tumors, you're probably going to have it come back. You need to get bigger margins. We're already talking about those being dangerous tumors and need chemo. But this brings up a really strong point, because you're sitting here saying to somebody, I mean, less than 3 millimeters, this is really, really narrow margins. But none of them recurred, and of all the low-grade tumors, they only had a 3.9% recurrence rate. So there's another paper, and I didn't include it, but I was talking about somebody the other day, on the extremities. We almost never get wide excisions on these extremities. You just don't have a lot of tissue to work with. So when you start to hit the legs, it becomes real problematic. So the question was, of those, are they all narrowly excised? Yeah, most of the mast cell tumors on the limbs are all narrowly excised. And in that paper, they were narrowly and incompletely excised low-grade mast cell tumors, and there was a lot of dogs. It was like 60 dogs. They had an 8% recurrence rate. So the take-home is, I think the recurrence rate's a lot lower than we always thought it was. I think there are a lot of dogs that went through radiation and stuff like that, it's not that they didn't benefit from it, but it certainly is not a scenario where I would expected all of those to recur. And so I do see a lot of these low grade now, and that we will take a wait and see approach. And I think that it stems from 2 things. I think it stems from we're doing a better job with surgery, and we're probably getting a fascial plane and getting some of that deeper tissue. And I think we're much, much better at our grading schemes. And I think if it's low grade, we're looking at it and we're identifying and saying that's a low grade tumor, it's not real aggressive, and you got a narrow margin, but I think that'll work. You know, and that's the way I'm looking at it. I think now if we put it as a high grade, I'm telling people we need to either go back to surgery or definitely get you on chemo. And probably the chemo's the direction we would be leaning with those high grade tumors. So I know that was kind of complicated and not super clear, but it gives you an idea of just a little bit of what we're seeing with the new grading scheme and maybe some food for thought for when you get these narrowly excised tumors. The next ones are fairly quick. So this is melanoma. It's about the vaccine again. So the vaccine, how does it work? Very similar to the other, when we talk about lymphoma, it's targeting a different protein called tyrosinase. Again, it's just stimulating the immune system to look for that. Question I get a lot, hey, do you feel that melanoma vaccine is effective? And the answer is yes. It's effective if you have local control. So that mass has to be removed out of the mouth. It has to be completely excised, or at least down to microscopic disease. And typically that's where we start to talk about either you got a pretty dang good flat excision and everything looks really good, or we went in and taken a segment of bone out if you have that oral mandibular melanoma. Dogs that have a complete excision and follow with a vaccine, with this study that they put out, Melanoma put out, it was really strong. It was showing that these guys were getting 389 days. They were getting out of about 12, 13 months. And that was either for some of the more aggressive stage 3, stage 4 tumors. Without the vaccine, these numbers have always been really low. Like 2 or 3 months, we were seeing this tumor come back or show up in a lymph node or somewhere else in the body. So we know that the vaccine definitely made an impact. There was a big study that came out on the melanoma last year that really showed that again kind of confirmed some of that. I think maybe have that in here, but it really said, hey, like we know the melanoma vaccine works. What's the negative to it? You need to have local control. I mean, that's the negative to it is again, your immune system can only do so much. So if you have a big bulky tumor in the mouth, we got to come up with a plan. We have to have a discussion about removal. You can't really talk to the clients and say, well, you got this big one, I know you don't want to do the surgery, so just go and have the vaccine done, because I talked to a lot of people about it and say, no, it's just not a good option. If they've got big metastasis in their lungs, they're not a good candidate for it. It's not going to work. If they've got a big lymph node, it's not going to work unless we remove the lymph node and get the tumor. So you really have to have that patient that's got microscopic disease. He just has an unfortunate diagnosis, and you're just trying to control it long term. And those dogs you can do well in the time frame. I usually quote about 12 or 13 months with the vaccine. The question I've gotten recently is, can you use it in other stuff? So can the melanoma vaccine be used for a digit melanoma or dermal melanoma or feline? Yeah. I mean, this thing melanoma vaccine has been safe, has been reported in both used in horses, it's been used in cats, it's been used for amelanotic melanomas. They don't have to actually have the melanotic appearance to them. They can be the pink, ugly amelanotic melanomas. That's still a little bit of a negative prognostic indicator, but it's definitely shown to be effective still in that. And I was talking to somebody about this today, and I still, as a veterinarian, it's still hard for me to wrap my mind. The dose is the same whether you're a cat or a horse. Same one. I still can't get that. We had this discussion. This is a funny one, I'll tell you. So we had this discussion, and I don't know, we did something like that, and I'm sure you don't mind, Dr. Roach brought it up one time. He's like, yeah, I can't wrap my mind. Like, how is a red blood cell the same size in a Great Dane and a Chihuahua? I'm like, what do you mean? He's like, it seems like that one should be like this and this one should be like that. And I'm like, it's true. I mean, I'm sitting there like wrapping my mind around it. I'm like, it is kind of a weird thing. Like, why would the cells be the same? But that's what goes on in our minds, if you're wondering. So this is the melanoma vaccine thing that I was telling you about. So they went back and looked. Since this thing hit the market in 2007 and went to 2016, they reported this last year. These were the patients that were treated. So they are some of the patients that were treated, 320 dogs total. And really the median survival time for these more aggressive tumors in the mouth was around 300 days. So we're definitely hitting on where we think we're supposed to be. There's some big time numbers that are thrown out there for some of the less aggressive tumors. But I mean, I think that year is about right, and it's just not. We just don't get the year with chemo. You do surgery and you follow with chemotherapy. I mean, consistently we're getting about 8 or 9 months. So we know the vaccine is safe. We know it's effective, and I think it does work. And I think it's something to consider in owners in dogs who owners are willing to come in and do the vaccine after surgery. But I do think the local control is a must to get that time frame. And the final one is hemangiosarcoma. I have a dog with a splenic mass. Is this definitely hemangiosarcoma? Splenic tumor always equal hemangiosarcoma equals bad? Is there a way to determine if this is hemangiosarcoma prior to going to surgery? I got an owner who doesn't want to go to surgery if it's a bad prognosis. Okay, so The answer to that usually is no. It's very difficult to determine whether it's truly hemangiosarcoma or hematoma or hemangioma. I mean, those are the three that we always think about. You're going to look at the spleen with an ultrasound. You're going to see this big, ugly splenic mass. But we are starting to actually make some headway in confirming prior to surgery which one you have. So the big thing right now that we're looking at is the Mast to splenic volume. And so what that means is, in layman's terms, big oftentimes equals benign. And so you end up with this dog that comes in, he's got this big, giant, ugly splenic mass, and we go to surgery and we take it out and it's this big honking mass, and the thing comes back as a hematoma or hemangioma. You'd have a dog that comes in with a hemoabdomen and he's got this kind of smallish, intermediate sized mass, and that's usually the ones that's going to be the hemangiosarcoma. So how do you rationalize that? Well, hemangiosarcomas grow fast, they're aggressive, they get to a certain size, they start bleeding, you get diagnosed. Hematomas, hemangiomas just sit there and get bigger and bigger and bigger and bigger and bigger, and they never spread, they never go anywhere, and then finally you bleed, but it's this big tumor by the time it does that. But that was the concept, that was the hypothesis that somebody had, so they went back and said, well, let's find some dogs that underwent splenectomy. So we took 65 dogs, underwent splenectomy, and looked at them, and the numbers are about what we quote. So I usually quote that about 66% or about 2/3 of dogs have splenic masses or malignant. And so that's pretty much what this is. In this study, 46% of dogs had hemangiosarcoma and 10% had other types of malignant masses. So 56 is what they came up with. Or no, actually that was the number. So 46 and 15. So it put it right there where I thought, like around that 60% category, 61%. So 2/3 was a number. So that was about what we expected it to be. And then you had about 40% of them that were benign. And so how do you pick up the benign ones, or how do you give the owners some thought? What they found was dogs with splenic masses, dogs with benign splenic masses had significantly higher mean mass to splenic volume ratio and a higher mean splenic weight as percentage to their body weight than dogs with hemangiosarcoma. So if you read that whole paper, I mean, basically they came up with this whole scenario where they were looking at how big they were and comparing them to the size of the dog, and they had this really neat chart, and it showed basically that if you were hitting on these numbers and your ratios were where they were supposed to be, and the dog was a certain size, but the mass was this size, that it was much more likely to be benign. I mean, the problem is what do you do with that information? Because I think it's still a little bit of a guess, because but it is certainly a scenario where I do talk to owners about it at the time, and when they have these really large ones, I'll say, this paper exists. I can't tell you 100% that's what you're dealing with here, but if it's my dog and it's this big giant mass that I'm looking at in the spleen, I'm usually saying, that paper shows that there's a strong potential that these large masses have more of a tendency to be benign. So your numbers may not be that you have a 60% or 66% chance of being malignant. It may be more like 50-50. Let's get it out of there, especially if they're on the fence about it. I think it's interesting. It's just I want to put it out there because I thought it was something that was kind of interesting, but I will talk to people about that. This one is another one that, and we haven't dove into this much. This is a brand new paper that came out August of 2018, so it just hit the paper here. But 57 dogs that received splenectomy, and basically what they looked at is they looked at the maximum lesion size on ultrasound was significantly different between malignant and benign tumors. And this is same kind of scenario, retrospective study, but they went back and said, hey, is the size of that thing diagnostic? This one again said, yeah, absolutely. This one was interesting because in it they also looked at CT. So they did a pre-contrast CT was significantly different between splenic malignant and benign tumors. So they actually took it one step further and they said, we're going to put these dogs on the scanner and scan them, not with just an ultrasound, but with the CT. We'll get the size, we can measure them on the CT, and then we can actually see kind of what their contrast looks like. And they actually figured out that in this one, that there was a big times difference between their contrast uptake and what they look pre and post and having a malignant tumor, which does make sense because if you think about it, your contrast is going to go through active live tissue that has a blood supply. If you got a big old blood clot sitting there, it's just not going to take up anything. So what's the problem with that? The problem with that is like most of these dogs present with hemoabdomen. So they're sitting there bleeding, and you're like, hey, let's go over here and put him on a CT scanner, and so it's kind of, you got to make a decision. But I think you will see more about this. And remember, this is brand new. I mean, this is stuff that's just coming out. But I do think, if you have a dog that comes with a hemangiosarcoma or has a splenic mass, let's back it up, has a splenic mass, and we're really on the fence. We know aspirates have been really unrewarded. You don't really want to biopsy it and make it bleed. There may be some benefit in doing some of these measurements and potentially even a CT. I think it's early. I mean, I think it's hard for me to go in a room and go, hey, this is definitely going to be benign because it's huge. But it's certainly kind of changing some of that dogma that we thought that every spleen that walked in had to be bad. I did a splenectomy, got my diagnosis as there options for my dog. These are the current numbers. I mean, with splenectomy alone for hemangiosarcoma, no chemotherapy, it's about 3 or 4 months. And then we usually see those dogs be happy, run around, play, have a good 3 or 4 months. But recurrence in the liver or another bleeding event, usually that's the time frame. With chemotherapy, if I do 4 to 5 doses of doxorubicin, which is typically the standard, we're seeing those dogs go about 6 to 8 months with chemotherapy and surgery. So chemotherapy, yes, I do recommend it. I think it doubles their survival time. I think these numbers are real. I think that if you have a splenectomy, it's hemangiosarcoma, you're treated with doxorubicin, then you're making your decisions on 6 to 8. I do have some dogs that have lived over a year and things like that, but to me, that's your deciding number right there if you're going to do chemotherapy and surgery. And then this is the final one. Is hemangiosarcoma hereditary or inherited? So this was a study that was done, multi-institutional study, and they had 204 golden retrievers. So this is they're doing this study called this golden retriever lifetime study, and this is some of that information that's coming out. So 204 golden retrievers with hemangiosarcoma, dogs that went on and collected and that had hemangiosarcoma. Those guys actually had gotten samples, and they are able to look at their genome now, and they identified that those dogs that had developed in the golden retrievers an association that they did have a change in their genome. There was a gene there that was different compared to other golden retrievers, and it was pretty consistent. And so after they went through this whole thing, the study uncovered a strong association between a genetic profile and the development of hemangiosarcoma in golden retrievers, and they come back with a final thing that said that golden retrievers have around a 20% lifetime risk of developing hemangiosarcoma. So that was that of that breed. They do think there's an inherited risk, and they do think that if you have a golden retriever, that's about your number that you would have. You have about 20% risk of going on and developing it. And it's a pretty interesting paper to read, because we always knew there was these certain breeds that were more predisposed to develop some of these tumors, but they actually put a number and said it's 20%. It's 20% is a risk factor that you run if you're a golden retriever to go on and develop that. And I think they gave an age of like 10 or 12 years old. That was the time frame. You have about 20% risk of developing it by that age. That is tonight's talk. I'll get you guys done. I thank you guys for coming out. So do you guys have any questions or anything at this point?
A while back they had an article in Scientific American dealing with melanoma in people, and they said that in one study, people that were on a probiotic that contained Bifidobacterium breve and longum were 50% more likely to survive melanoma. Any thoughts on that?
No, I mean there's definitely 2 or 3 papers on melanoma, and especially they really came out of horses, where they definitely put those horses on probiotics, and I never really knew why they were doing it, to be honest with you. So we don't do it a lot in dogs, and there's not a lot of papers in dogs about it. I think there are definitely thought to be. There's thought to be some immunostimulus that's happening there, and that's why the melanoma vaccine exists. That's why this immunotherapy has they selected melanoma to start in it. So that would be my hypothesis behind it, is that yes, the benefit is it's somehow stimulating the immune system to help control the disease. I'm just not really sure how it's identifying the cells it needs to identify, which is what the melanoma vaccine was trying to do. But melanoma is a weird one, because it's definitely one that we failed pretty miserably with chemo to do a whole lot in people and in dogs, and it's one that's really tough to treat with radiation. I mean, most of these tumors are fairly resistant, and I think it's because your melanocytes are pigment. They're supposed to protect you from solar damage, so then you try to treat it with radiation, it doesn't work. I mean, they're supposed to be really tough cells, but they seem to be fairly responsive to the immune system. And so that would be my hypothesis behind it. it is that there's some immune modulation that helps you attack it. And certainly you will see, like I said, you'll see a lot of these guys that have these gray mares that will develop these melanomas, and they will put them on a lot of probiotics and different stimulants and immune boosters, and they definitely, I've seen papers that come out that show that the tumors regress or that they stay in remission longer after they're removed, and so it doesn't surprise me. I mean, it sounds like a reasonable thing. All right, guys. Well, thank you very much for coming out. I do appreciate it.